It is now my pleasure to turn today's program over to Charles Gluck. Charles, the floor is yours.
Thank you very much. Hello, everyone. Thank you for joining us. I want to welcome you to today's learning event on comprehensive medication management in primary care. As always, type in your questions throughout the webinar. We'll get to as many as we can. For those we aren't able to answer, we'll provide additional information on CPC Plus Connect, as well as in the frequently asked questions you receive in your newsletter. Now I'll turn the presentation over to Amy Gibson.
Thanks so much, Charles. And again, welcome to everybody. We are really excited to have everybody here today, and you're going to be so pleased to hear from our speakers today. We have some real experts in comprehensive medication management with us today. We have joining us our CMS experts, Captain Joshua Devine and Lieutenant Commander James Lee. I really want to encourage you to bring all your questions that you have around medication management today. We know this is a new requirement. We're going to give you a lot of great information about that. But as Charles pointed out, at any time during the presentation, you can chat those in, and we'll get to as many as we can at the close of before the close of our call today. We have Jennifer Boaz and Stephanie Plum, also from the National Learning Team, who will be monitoring those questions and getting as many of them over to us as we can answer today. And as Charles pointed out, we'll provide additional information and clarification for any of those we can't get to over on Connect. In addition to our experts from CMS, we are absolutely thrilled to have two fantastic CPC Plus practice teams joining us. And they've already got some experience that they want to share with you today about providing comprehensive medication management services in their practices. They'll also be available to respond to your questions. So again, any questions that you have for any of our speakers, please do go ahead and chat that in. So because we have a lot of content to cover, I want to get right over to introducing our practice speakers. And let's start with Arkansas Health Group. Kristen, why don't you go ahead and introduce yourself, and Jeff, and tell us a little bit about your practice and your roles there.
Sure. Well, thank you for including me. My name is Kristen Ballou, and I'm proud to be coming from Baptist Health in Arkansas. I have joined the care coordination team within the last 6 months. And so we are just getting our feet wet, but we're excited about the steps that we're taking. I'm currently located in the West Clinic with one provider, but I field referrals from several different clinics. We actually have a network of 21 clinics in our state. So we are planning to expand, but at the moment we're just getting our feet wet, and we're excited about integrating a pharmacist and exploring the options with CMM.
And I'm Jeff Oliver, and as Kristen mentioned, we are part of 21 CPC Plus clinics located in Central Arkansas. 16 of those clinics are Track 2 clinics. The other 5 are Track 1, and we're really excited about the opportunity to share what we have learned as we begin this process of comprehensive medication management, and also hopefully learn from you guys also.
Fantastic. Thanks so much. We'll be hearing from you real soon. And we also have with us our friends from OSU. So Dr. Tile, why don't you introduce yourself and Stu and your practice there in Ohio?
Sure. Thanks, Amy. My name is Niraj Tile. I'm the Division Director for General Internal Medicine here at the Ohio State Wexner Medical Center. We're a fairly large academic group. We've got 8 primary care clinics spread throughout the city of Columbus. We have about 60 physicians that practice throughout that network. We also teach a lot of residents. We have about 100 residents that work in our continuity clinics. We've transitioned over to having pretty enhanced care teams. We actually have 9 clinical pharmacists now distributed through that network, along with nurse case managers and social workers. We started down the path of having clinical pharmacists in our practice back in 2008. And obviously with the CPC program have really heavily invested in expanding that specialty into our practices. So they've over the years developed an ever-expanding portfolio of medication management services, and we're happy to share some of those experiences with participants today. And I think, Stu, if you want to make a comment just about your background there.
Sure. Thanks, Dr. Tile. Thanks, Amy, for having us. So I'm Stu Beatty. I was actually the first pharmacist to enter the OSU General Internal Medicine group. I'm a shared faculty member, so I'm also on faculty at the OSU College of Pharmacy, so I'm kind of a 50-50 split but started there really with the medical residence clinic. And then as Dr. Tile mentioned, we've expanded quite a bit. Now we've got a group of 9 pharmacists across our network.
Fantastic. Well, as you can tell, we're going to hear from both practices with a wide range of experiences. So again, please start bringing your questions forward. So we're going to hear more from both of you in just a moment here. Did want to just give a quick review of what we're hoping to accomplish today. So again, we're going to really talk about what that definition of comprehensive medication management is specific to CPC Plus, and really how those new CMM requirements are aligned to your overall goals and aims of CPC Plus. We'll talk about who should be providing those CMM services and which patients you should be identifying that can really receive the most benefit from those services. And then again, you're going to hear from our practices about some of those successful approaches and strategies that they've used to implement this in their practices. So with that, I'm going to turn it right over to Captain Devine, and he's going to tell us more about this within CPC Plus.
Hey, thanks, Amy. Good afternoon, everybody. It's definitely a pleasure to be here with James talking to you about comprehensive medication management. We're also thrilled to be joined by some of our practice participants as well. And so to kind of kick things off, we thought we'd start with the beginning and talk a little bit more about what CMM actually looks like under CPC Plus. To start things off, we wanted to mention that, first, and I think most practices are going to be aware of this, but CMM, and we'll use that abbreviation throughout today's webinar for comprehensive medication management, but CMM is a new requirement in 2018. It's actually part of our comprehensiveness and coordination function, CPC Plus. So if you're looking for details in some of our model resources, such as the implementation guide and other things that we'll mention today, that's most likely where you'll find it. And when we talk about CMM, what we're really talking about is an approach to care that's designed around trying to ensure that patients' medications are individually assessed. And, the focus of that assessment is looking at making a determination about, whether or not that medication is appropriate for the patient. We think about it in terms of is that medication that they're taking or receiving effective for the medical condition that it's been prescribed for? Is it safe given the other comorbidities that a patient may have, as well as in context of the other medications that patient may be on? And, is the patient able to take the medication as intended? And that last part is important. We wanted to highlight that a bit because I think oftentimes we think about reviewing patients' medications in the context of, safety, efficacy, and appropriateness, but CMM also really provides a good platform to think about and have a conversation with patients and caregivers to help address some of the challenges that may be barriers, if you will, to preventing what we kind of are aiming for, which is, an optimal therapeutic outcome. So, like, for example, if a patient may be having difficulties with a particular dosage form or prescription because of possibly financial constraints or lack of transportation to the pharmacy to get access to that, and that may be having an impact on their adherence. Those are things that can also be incorporated as part of the comprehensive medication management work to see what steps we might be able to take with their drug therapy plan to mitigate against some of those challenges. And really, our goal in CPC Plus is to create kind of a framework where comprehensive medication management can be provided collaboratively between the primary care team and the CMM specialist, who we'll talk more about, as today's session goes on, with the goal of working towards, supporting both patients and their caregivers in delivering high-quality medication management services. As we transition to the next slide, I'll pass it over to James to talk a little bit more about some of the core elements that actually make up CMM services.
Hi, thanks, Josh. And good afternoon to most of you, and good morning to those in the Hawaii region that are 6 hours behind the East Coast. Thank you for joining us. So with this slide, we recognize that comprehensive medication management will vary from practice to practice, and therefore there really is no one-size-fits-all CMM system. However, we do believe that CMM will at the very least involve these 4 core elements. And it begins with your care team identifying which high-risk patients would be a great candidate to receive CMM services. For the purpose of this model of CPC Plus, we want Track 2 practices to focus on delivering CMM services to a subset of patients recently discharged from the hospital and those receiving longitudinal care. I want to emphasize that this step involves more than practices identifying high-risk patients, but equally as important, to also recognize and consider the availability of CMM service resources within your practice and community, and understanding the capacity at which your practice can even support CMM services. So next, we have assessment of the patient, which involves CMM specialists reviewing medication records, obtaining a complete medical history, and building a relationship with the patient to further understand all challenges the patient may be facing that is preventing optimal therapeutic outcomes. And just like Captain Devine mentioned, CMM services is more than just reviewing and analyzing data and medical records. It really is building the relationship with the patient to further understand what exactly is holding them back. There may be a lot of non-medical issues that the patient may be facing that is preventing the optimal therapeutic outcome. And then, based on this collective information, the CMM specialist, in collaboration with a primary care team, will develop an individualized action plan, and of course, follow up to monitor and readjust the action plan when necessary. Next slide, please. So some of you may be wondering, how does this differ from medication reconciliation, which is a process that most, if not all, primary care practices already perform. Medication reconciliation, which is the process of creating the most up-to-date list of medications that patients are currently taking, and also to make sure patients aren't taking medications they shouldn't. So how does this differ from CMM? Medication reconciliation is the starting point for optimal CMM services. And what do I mean by that? A CMM specialist will take the accurate patient medication profile and incorporate the patient's preferences, needs, and challenges, which is the information received through relationship building between the patient, caregiver, CMM specialist, and the primary care team. From this information, in combination with the close relationships, an individualized action plan will be created to optimize therapeutic outcomes.
Okay, so I think as we transition, we wanted to spend a little bit of time thinking about, the patient population around who should receive comprehensive medication management. That's another, I think, question as practices start thinking about how to provide these services that typically comes up. And as James mentioned during the core elements, and we'll talk a little bit more about as we go into the actual requirement for 2018, we're really targeting into two groups for practices initially to think about. And those groups are, one, patients who've recently been discharged from the hospital, or two, patients who are undergoing longitudinal care management within the practice. And wanted to share a little bit about the rationale there. We felt that this was really a more focused population for practices that they've already engaged with through some of the other elements of their CPC Plus work. So particularly for practices where this is going to be a new move, that it would align well with some of the other work that they're doing. Also, we know that these patients tend to have higher risks of experiencing drug therapy-related problems, which can be addressed via comprehensive medication management. So we felt it was an appropriate place to start in kind of an environment where practices would be able to get their arms around that patient population for some of the planning work that's going to go on this year. We did also want to kind of highlight that this does not mean that everyone in those groups should receive comprehensive medication management. Oftentimes there can be patients within those groups that actually are not experiencing any drug therapy problems at the moment and may not be a good candidate. However, we also know that there could be patients that do seem to have a potential issue that we might want to take a closer look at. And really those patients are the ones who might be appropriate candidates for this type of service. And we've listed some of the things that a practice might think about as they're developing kind of the criteria that they want to use to determine who might receive comprehensive medication management. And some examples on the slide include, if the patient's taking a high-risk medication, for instance. So, for example, some of our quality measures are focused on, high-risk medication exposure in the elderly. That could potentially be a trigger. Another one that comes up is if it's clear a patient may not be reaching the intended goals of their drug therapy, or if they've been experiencing some type of adverse event which is impacting their ability to adhere with treatment. Those could be things that a CMM provider could help address and develop opportunities to kind of make some adjustments and hopefully improve that patient's ability to kind of reach those target endpoints. Also, if they've had some difficulties understanding how to follow their medication, sometimes they just need some additional education and attention and try to understand how best to kind of follow the instructions and treatment plan as it's been described. These can all be different reasons that practice may use to kind of determine within those patient groups who might be a good candidate, and use that as a platform to kind of decide which patients will be referred on for additional support. The last thing I wanted to mention here is, it's not our intent in any way to create the place where the practices would feel limited by this. I think James and I and others on the team really believe that the practices know best about, what's going to be of most benefit for the patients that you care for. And so in thinking about, who should receive comprehensive medication management, we really wanted to encourage practices to think about this as kind of that initial starting point. We know there are practices like you'll hear from today, for example, that have had a lot more experience and time to develop those services. And so what you'll find is that, I think as practices become more comfortable in offering this type of support to their patients, there could be other populations that would benefit from this. And, the goal here is for practices to have flexibility to expand this to meet the needs of their patients that they serve. Amy, I'll turn it over to you because I think we wanted to pause here and pose some questions to our panelists.
Yeah, absolutely. So Kristen, let's hear from you first. So in the context of everything that Captain Devine just described, and you guys just really getting started on offering these services to your patients, how are you targeting patients that you think would really get the best benefit from the services that you're providing? And then how do you identify those, or how are they getting referred to you as the CMM specialist?
Yeah, so I think many good points have already been spoken. The only thing I really want to add is that I tend to lean more towards our elderly patients. I tend to kind of focus in on those patients that are above 65 for a couple of reasons. One is they are more at risk. They're more at risk for either high-risk meds or maybe, decrease in kidney function, things like that may require extra medication management. Fall risk, because if their medicines make them dizzy or tired or whatever, they just seem to be a little bit more high risk. I also will say that I think elderly patients appreciate it a little bit more, and they appreciate the extra time and effort that you put into going over their medications to explain how and why they're taking this. And I oftentimes will actually schedule appointments with these patients and ask them to come in and bring their medication bottles with them, and we'll go through one by one to make sure that they understand everything they need to know about that medication. And that can either be chosen through, reports that we can run on measures, or in my case, a lot of times that happens with referrals from either care coordinators at other clinics or providers.
Thank you, Kristen. So Stu and Dr. Tile, you guys have been doing this for a while. Have you developed a particular protocol, or how are you identifying the patients that you really want to target for CMM services?
Sure. So this is Dr. Tile. I'll try to keep my comments brief, but yeah, we've had a fair number of years of experience. One of the things we do very deliberately is place our pharmacists in really close proximity to where the clinical activities are going. So they'll be intimately placed where the physicians and the patients are. And a lot of times we identify people, while they're in clinic. It's not an uncommon experience for somebody to just be initiating insulin therapy, or maybe they're struggling with their inhalers and not getting adequate control of their COPD or asthma. A new AFib patient or DVT patient that needs to start anticoagulation, or maybe a patient that's got a large number of meds. It's not uncommon for us to have patients with more than 15 meds on their med list, and it's just not really sure that they know if they're taking those correctly. So a lot of times just on the fly we'll bring pharmacists in, and over time it takes a fairly short amount of time for physicians to recognize the real value that they bring in, that they can spend the extra time to ensure that patients know how to take some of these high-risk medications and are educated on proper technique. So that's one area. The other area that we've done a lot of work on is in benzodiazepine and opioids. Obviously, you read in the news about the crisis as far as overuse of some of these meds. So our clinical pharmacists a lot of times will sit down with patients and develop a weaning protocol that's quite extended so the patients avoid side effects and can get a lot of support. The pharmacists will commonly call them on a weekly basis to assess for side effects, and we've had a great deal of success with that approach. I guess probably the biggest thing I like to say for what our pharmacists have learned to do is sort of provide concierge service, but instead of for patients that have a lot of resources, we just try to target patients that have complex care plans related to their meds and barriers to care, and our pharmacists work really closely with those patients. And they'll actually add their names to the care team. So in our EMR, a pharmacist can add their name to a care team just like a physician, primary care physician can be, and they'll follow those patients for as long as it takes until they're stabilized. And we've had great cases of patients that were semi-homeless, maybe suffering from blood clots or suffering from heart failure or Parkinson's, and they just stayed, real close with them and did lots of follow-up calls, and commonly doing the kind of work physicians simply don't have time to do. Real briefly, a couple other things where they intersect with our patients is obviously calling. We have them call our high-risk patients for readmission. So our patients that are discharged, we develop a registry that actually calculates what their risk of readmission is, and we have our clinical pharmacists call the patients that are at the highest risk, mostly because what we've seen is they're usually medication-related issues. And then the last thing where we've gotten our pharmacists really involved is in population health activities. Our EMR generates registries, and we've had them engaged in programs to decrease cardiovascular risk. We're part of a Million Hearts program sponsored by CMS where we calculate cardiac risk and have the pharmacists work with those patients that have a greater than 30% risk of a heart attack or stroke. So lots of activities, but really the key is just trying to find those patients that would benefit the most, whether it's on the fly in clinic or a more systematic approach with calling off of registries. So I'll stop there for the sake of time.
No, that's fantastic, and I think you've really given a lot of the practices on the call something to aspire to, that when you fully got a pharmacist embedded into the care team, you're able to do those warm handoffs and those really quick, just-in-time consultations, which I think is a really great goal, and clearly you're seeing the real benefits of that. So thanks for that. And Kristen, to you as well. So Captain Devine, why don't you tell us a little bit more, and I think we've already started to allude to this, but the benefits of CMM and why it's become a CPC Plus requirement.
Yeah, absolutely, Amy. And I think this is an interesting question and one that comes up from time to time. And I think that, one of the main reasons is just that we understand and see firsthand how much that medications are involved in treatment plans today for patients. I mean, I think the vast majority of patients that are being managed, especially ones with chronic disease, will have interaction with medication to kind of help manage those conditions. And really those medications can affect almost every aspect of a patient's life. So particularly when problems come up with patients' drug therapy, that can have negative impacts on their quality of life, on their experience of care, and we know too that it can lead to greater healthcare utilization and higher total cost of care. So really, I think the decision to try to include this as part of the CPC Plus model was based on the premise that much of the evidence that we've collected over the last decade has highlighted, the impact that comprehensive medication management can have to really help us change this trajectory, to try to proactively identify and address some of the drug therapy problems that you just heard our panelists talk about. Pharmacists in particular can really help, I think, as part of the care team, address some of those issues, whether you're talking about maybe inadequate therapy in some cases or non-adherence, patients who need dosages. There's a variety of different, medication-related problems that they can assist with the goal to help improve their outcomes. And I really think, at the end of the day, if you just take a step back and you look at the goals around CPC Plus model, honestly, CMM support seems to align very well, and we believe will help practices achieve the aims of CPC Plus, better care and improved health outcomes for patients while trying to be smarter about how we spend our healthcare dollars.
Fantastic. James, do you want to tell us a little bit about how we are thinking that practices might start to evolve these services and start to really integrate them into the practice as part of this requirement that we have in CPC Plus?
Sure. Thanks, Amy. So we recognize that CPC Plus is a model with a steep learning curve. As a region lead, I've heard many stories from practices how they are struggling and challenged with all the requirements in CPC Plus. And but we also believe in the benefits of comprehensive medication management and what it could provide for the practices and the patients as well. So for 2018, we wanted to start small with comprehensive medication management and really focus it towards the Track 2 practices in CPC Plus. So the requirement is for Track 2 only is to develop a plan to provide comprehensive medication management to a subset of patients discharged from the hospital and those receiving longitudinal care management. Now, the focus is on Track 2 practices, but we also want to emphasize that, we would support any Track 1 practice that was also interested and believe in the benefits of CMM for their patients. So even though this particular requirement for 2018 is for Track 2 practices, Track 1 practices are more than welcome to provide the service as well. So if you look at the chart, you can also, we recognize that this is just a suggestion, in terms of timeline of how you want to progress and implement CMM for your practice. We feel that, it would be a good start to identify resources and identify what the capacity of your practice can do in terms of supporting CMM services. And when you can, design and test a workflow to integrate medication management. We recognize that if your practice is especially new to CMM, your first go at this may or may not work. But the important part is you learn from it and you adjust and you try it again. And hopefully by the end of 2018, your practice will begin to implement comprehensive medication management services to a subset of your population. So who can provide CMM services? So that we get this question a lot from a lot of the practices, and naturally, just like all of you, the first choice would probably be a pharmacist. It just seems ideally the perfect provider in terms of background, education, and experience to provide the services that needed for a CMM specialist. But we also recognize that a eligible and suitable, well-trained pharmacist may not be accessible for all practices in all the regions. So therefore, we also want to emphasize that a practitioner or provider with prescriptive authority, so who do I mean by that? Medical doctors, DOs, nurse practitioners, and physician assistants, we feel that are also well-trained and experienced in CMM, are also very suitable to provide CMM services for your practice and your patients. Ideally, sure, we recognize that pharmacists can provide the services, but also we want practices to be aware that there are other opportunities for other practitioners to provide the services, just in case you don't find a suitable pharmacist nearby, or perhaps a pharmacist is close by, but they don't feel comfortable, or maybe they just don't provide CMM services. So it's good to keep in mind, especially for the more rural locations, that there are options out there, and your choice of CMM specialist may not necessarily be a pharmacist. And I think we're going to pause right here.
Yeah. I wanted to hear from Kristen and Stu. So now, obviously, you guys are both pharmacists. Kristen, can you talk a little bit about how, especially knowing that you just got started in this role in your practice, talk a little bit to us about how you've integrated your role into the care team, how you're starting to work with other members of the practice, both to identify patients and how you see your role as being unique and your training is situated in a way that you can provide some more enhanced care to your patients.
Well, sure. So being new in this role, I think there is a learning curve also for the coworkers that you work with in a clinic. A lot of times they don't even know what kind of questions that they can ask a pharmacist or how we can help. And so I've really tried to build relationships with our care coordination team. We have at least one care coordinator in each clinic, and by sharing knowledge of the measures, by teaching, by just getting out and really helping some of those lower performing clinics, then it starts a conversation that will always lead to a referral. And, you know, while it's great to be inside a clinic, because we're so spread out in a network, I do have to keep my time more free and available for referrals, which means I can't be as plugged into the everyday workflow of a clinic. And that's just because we're still in the infancy stages of introducing and implementing a pharmacist. But we are looking forward to hiring more and then hopefully becoming more established in workflows. But in the infancy stages, I really feel like it's so much about teaching, building relationships, and then being available for referrals.
That's great, Kristen. What about you, Stu, and the pharmacists that you're working with in the practices? How do you really get the care team to embrace the role of the pharmacist and really get that full integration that it sounds like you've accomplished as part of the practice care team?
Sure. I think, first off, I think Dr. Tile covered this a little bit of what our journey's been. And since we've been doing this a little bit longer, I think maybe some of the newer practices are going through stuff that we've worked through. So I think one of the things is to have something that's a fairly defined role, and that's, I would say, by identifying some of these high-risk populations or identifying a group of patients for your pharmacist to engage in early on has been really beneficial to us. And as the speaker just mentioned, I think starting small and working at this almost like a pilot program with a small subgroup of patients. If you have one or two physicians that are kind of your early adapters, start with them so you can start to work through that workflow. Realize it's not going to be perfect right off the bat as everybody kind of figures this out. I think that's what's been key to us. I think as far as one of the things I've found is we have a large number of physicians, but having your physicians actually tell and set the stage for your patients that there's going to be other people involved in your care. And that's a little different for patients. That's different than where we've been in healthcare. But Dr. Tile's on the line, and I'd say he's as good as that with our practice as anyone. But he will tell all of his patients, I'm not the only one that's caring for you. So there may be a nurse that's reaching out to you. There may be a pharmacist. This is my pharmacist's name. If we happen to be there, he'll pull us in the room and be like, this is the person that's going to be calling you to follow up on something. And I think establishing that rapport with the patient makes a lot of sense early on as well. So I think, I guess that's where we've started. We've tried to identify those high-risk patients. We've tried to go after things like transitions of care, some of those different initiatives, being embedded and being right next to the providers and the nurses as much as possible, I think really makes that relationship work well, because then people start to realize, when can I triage to you? When can you triage to me? Who's going to follow up on this? Can really help with that referral process. I realize that takes some time, and I don't expect everybody to be there tomorrow or be where we are, where we're lucky enough to have a pharmacist in each one of our clinics, but also realize we didn't get there overnight either, and it's kind of been a gradual process. And as we've had more of the providers and more patients kind of buy into what we're doing and taking on more initiatives, and again, having that CPC plus, some of that funding to be able to justify bringing our pharmacist on board.
That's a great description, Stu. And really what you described doesn't sound much different from any integration of a new member onto the care team. And really, I think what you pointed out, having that physician champion is so critically important to really creating and establishing that culture of team-based care. And then once you get to the point where you've really been fully integrated, how really everyone on the care team understands and appreciates the various levels of expertise that everyone brings to that team and to the care of the patients, and the patients really appreciate that too. So thanks for that, Stu and Kristen. Really appreciate that. Josh, maybe you can talk a little bit more about some of the other options for practices as they're looking to integrate CMM specialists into their care teams.
Yeah, absolutely, Amy. I know that in talking with practices, especially practices who may be, just approaching this work, kind of new to this area, that one of the challenges that we hear about is trying to figure out, like, how do I engage with pharmacists and, how should I think about trying to do that? Because it may be an area that you as a practice haven't delved into before. That was part of the reason that we opted for more of a planning requirement. As James mentioned, the requirement this year is really to use this time to help kind of develop a plan for how you might implement that. And part of that plan, we believe, would include, almost like an environmental scan in your area to kind of think about, like, what are my options? And we thought it might be helpful to kind of list some of the things that we've heard from practices that have worked to kind of get, some of those thought processes going. We've heard from practices, and those are kind of shown here on the slide on the left-hand side, but some practices have decided to go the route where they've actually hired someone into their practice, a pharmacist perhaps, to help implement and support this work. We've also heard about practices handling it more in kind of a contract arrangement with practice resources in the community. Community resources are another important area. I know we've seen some questions that came into the chat already kind of talking about how to do that, but some pharmacies and some community resources are, I think, already potentially available and interested in this kind of work and finding out who those may be and allowing, your practice to kind of engage and talk with and learn more about what the options are in your particular area can be very helpful. I know we have many practices that are part of health systems that may have some of these resources available elsewhere in the health system, and so we've heard from practices that have been able to kind of successfully develop relationships with comprehensive medication management support in mind via some of those connections. ACOs come into play here as well. If an accountable care organization has some of those resources available, that could be an avenue of discussion within the practice. We've heard a lot about tapping into academic resources as well. Certainly colleges of pharmacy can be a great resource both for being able to connect with clinical faculty, at the college, as well as, new professional students that are going through the program looking for training opportunities. Definitely a great opportunity. And then we also wanted to mention state professional associations, because many times, they may have within the state a good idea of, which pharmacy resources may be suitable or appropriate for a practice to engage with, and so can be something to think about as you're, kind of engaging in some of your planning work.
That's fantastic. And so as we were just talking about how you really get started in this, and James, you already alluded to a lot of this in terms of, there's not one progression that's going to be applicable to all practices, but as practices are starting to think about this integration and offering these services, what do you think are some of those important areas that they really need to start considering?
Thanks, Amy. So as Amy mentioned, there is no one-size-fits-all in terms of how you're going to progress and implement and plan CMM services for your patients in your practice. So with this slide, we wanted to highlight some key ideas or thoughts that, especially for the new practices that aren't familiar with CMM services, that you might want to think about these questions and ask your team these questions when you're beginning to really start from the beginning. for example, determining how your practice will benefit from CMM, identifying the role a CMM specialist will play at your practice. These are important questions to really identify what type of services that you're looking for and to meet the needs of your patient population. Every patient population and every practice is a little bit different, culturally different challenges, and you really need to identify someone that can meet those challenges and find solutions for those challenges. So I think that our point for this is that this is not an all-inclusive list of things to look for. Sure, there are many, many more considerations, but feel that this list is just a good starting point and for your team to start thinking about the needs of your patients.
Fantastic. So, Kristen, you guys have just gotten started on this, and maybe Jeff can speak to this too, just in terms of as you've already thought over the last several months and you've started this integration in your practice, what are some of the things that you found that have been really successful in helping to integrate your role as a pharmacist onto the care team? And what are some specific key strategies that you would suggest to practices as they are getting started on this work? Oh, Kristen, you might be on mute. We can't hear you. Well, Kristen,
yeah, I'm still on. I didn't
I
didn't know if Jeff wanted to jump in.
I will. Some of the things have already been mentioned. Obviously, as a startup, one of the first things we want to do is make sure that we can identify those patients, which has already been mentioned. We will start with those that we already are doing things for, such as the transitional care patients, the high-risk patients, those in longitudinal care that you develop that relationship with. So I think as any startup, you want to start with a process that you're already doing so it doesn't feel like you're adding additional things onto someone's casework. So that's the main thing we're looking at. We're looking at, because we have 16 clinics that are in Track 2, and there is a variety of experiences there. There is a variety of different types of clinics from one provider. It's 10 providers within those clinics, centrally located where there's lots of resources to be in rural clinics. So as also mentioned, we've got to develop processes that would be best for those particular clinics and something that they can achieve without having to make a cookie-cutter type approach to all of it. So all the things that have been mentioned are really answer that question. We got to look at the things that are going to have the biggest impact and also fit the best within our workflows.
That's great. Thanks for that, Jeff. Dr. Tile and Stu, you've been doing this for a while. Are there any particular strategies that you found that had really a lot of success in terms of doing this work, or even maybe any hiccups along the way, that things that you tried that maybe didn't go so well? Any recommendations, advice you have for practices?
Stu, why don't you go first?
You'll let me go first, do you think?
Yeah.
No, I think similar to what we've said. I think starting small, don't start with some extremely big initiative and think you're going to get all the answers and you're going to solve all the world's problems right away. So I think one of the things that we've learned is starting with a small group. So for example, we've had some initiatives where we've looked at all of our patients to try to optimize their statin use with ASCVD risk. So when we first started that workflow, we started that with just 2 or 3 of our physicians to kind of figure out, okay, once we get these reports in and we've identified these patients, what's the next step? So our pharmacists are going to go through and kind of review that patient's chart and make sure that are there any allergies that are in there? Are they on the right dose? Are they adherent to the medicine? And then we're going to talk to the physician again. Then we're going to reach out to the patient. So we did that when we first started. We did that with just a couple of our physicians to kind of see how that workflow worked, and we definitely made changes to that workflow, and we made changes to how we would document that and how we would make those recommendations. And then once we kind of became comfortable with that workflow, we rolled that out across our entire network. So that's just one example. We've kind of done similar things in a population management or in a risk stratification manner. I think the other thing, which again I think we've hit on a few times, is that we feel it's critical to have the pharmacist embedded, and they're right there to establish that relationship. So maybe we're working on these certain initiatives with CPC Plus, but by having a pharmacist there, there's going to be a patient that comes in that doesn't fit into a certain metric that needs to be tracked, but the physician's like, man, this patient really needs a lot of help. I know that I can go over here to this pharmacist, and they can either come into the room or they can follow up with that patient. They may call the pharmacy where the medicines are dispensed. They may help with an insurance issue, whatever the case may be. By having them embedded, they're right there to be able to help solve those problems. So I would say those are the biggest things. Make sure you're piloting, and again, for us, it's embedded. And if you can't have a pharmacist at your clinic full-time every single day, I mean, maybe you're at least having somebody across your network, you're having them rotate through that site, so then they can at least start to realize, well, I know that every Tuesday my pharmacist is going to be here, so I'm going to start to leave notes or identify patients, so when they come in on Tuesday, here's somebody that I want you to look over. You can kind of start that relationship that way, and you can kind of see where it goes from there. I don't know if you have anything to add to that, Dr. Tile.
Yeah, I'll just briefly, you're right. I mean, we sort of really feel strongly that trust builds when people work in close proximity to each other. So we're always trying to leverage that natural team building element. So we always want our pharmacists embedded close. But it doesn't mean they can't also function centrally, because with a lot of electronic medical records, they can coordinate across 7 clinics. So we have pools. We have a pharmacy pool. So you can send a patient case to an individual pharmacist, or you can send it to the pharmacy pool, in which case, just as an example, and Stu would support this, we have 2 pharmacists on call each day, and they do all of our transition calls for the entire network. That way, so they have a focused effort at their local clinic, intimately with the patients and docs, but then they also have services they provide on a more centralized basis to the entire network. So it's actually a nice balance of the two, and it creates some redundancy and some resilience into our system in case we have absent staff or anything. So that's the only other tip I would give folks, is try to have the mix of locally embedded staff, but also build your EMR systems and communication systems around the ability to leverage that across a centralized strategy.
That's great. Thanks so much for that. And that also sounds too, Kristen and Jeff, how you've been operating too, doing some of those services embedded within the practice, but then also being available for some of those referrals centrally. So it sounds like that's a really good strategy, and would recommend that for practices. So as practices are really starting to dig in and do this work, there are some reporting that and some data we're going to be collecting from practices along the way. And so, Josh, maybe you can speak a little bit to that.
Yeah, that's right. We, occasionally we'll get questions about how are you going to kind of evaluate or monitor the progress that practices are making, and so we wanted to share just a little bit of information there. In particular with comprehensive medication management, where you'll see some of this come into play is in the care delivery questions that practices answer quarterly. Right now we have comprehensive medication management questions, I think, targeted for Q2 and Q4. Not many, I think just really 2 questions, and you can see those in the implementation guide, but we thought we'd mention it here just for awareness, because that's really going to be one of the ways in which we get a sense for how our Track 2 practices are doing around planning and implementing and testing some of the comprehensive medication management work. The first question is really talking more about how practices are doing at implementing and what areas have you been able to implement. And so it'll be an opportunity to kind of indicate in that question at the end of Q2 how and to which entities you've been able to kind of successfully work on at your practice level. And then we'll have a second question that we'll actually ask, have you started to test? You've heard a lot of conversation today about testing some of your initial plans. We believe that can be really helpful for practices as they're working through some of those, new kind of programmatic issues. So, one of the questions we'll also ask about whether or not you've been able to test any of your CMM work, and that can be, on a limited scale to kind of pilot some of the workflow design issues that you've come up with. And if you answer that in the affirmative that yes, you have, then there'll be a few just minor or simple follow-up questions that talk kind of more about, who's actually providing the service, and where are you kind of focusing on your CMM work. And that's really going to be helpful for us as we try to get a sense for how practices are doing, as they start working on it. And so wanted to mention that today so that folks can be on the lookout for that as you respond to those care delivery questions in the next year.
And speaking of questions, I've seen a lot of fantastic questions come through, and I want to try to get to as many of those as we can. So, Jennifer, I know you've been pulling a lot of those over. If you want to go ahead and start asking our practices and our colleagues at CMS some of those questions, we'll do the very best we can.
Yeah, thanks, Amy. We've had a lot of questions around kind of the operational aspect of implementing CMM into the clinical workflow. And one of the questions that came up is around what data can be used to identify those patients who would benefit from CMM. And I know we kind of talked about those patients that are recently discharged from the hospital, patients in longitudinal care management, and those can be data points. But for our panelists today, just kind of curious what data that you use to help identify those patients for comprehensive medication management.
Maybe Stu and Dr. Tile, you can speak to that first.
Sure, this is Stu. Yeah. We've done a few different initiatives, and I think the one thing that we try to do as much as anything is we're trying to utilize our EMR to help identify our patients and our high-risk patients. So I think what I would share and what we've had the most success with is start with a fairly specific initiative that's got some that's guideline driven or is fairly black and white with what the outcome may be. So that way you can identify those patients, and then you can have the pharmacist review that chart or kind of come up with what the intervention strategy may be. So, for example, I talked about our statin optimization. We've done things with high-risk medications where we've identified folks on benzodiazepines or on bisphosphonates or some of those. We've done PPIs in our geriatric population. Some of those things that are out there in the literature that we know we need help with, and they just aren't being done in the primary care setting. So kind of that low-hanging fruit we can go after. We can develop a protocol around it, have somebody review it, and go from there. Other things that we have done is we've looked at more disease states instead of just looking at medication. So we've looked at our diabetes population that's uncontrolled, or we've looked at our hypertension population that's uncontrolled. And typically what we do is we may say, here's a list of our patients with an A1C above 9%, and then we'll sit down with the primary care provider and say, all right, you've got 20 patients that have an A1C above 9%. Of that 20, who are the people that you feel like, you know the patient, who do you feel like the pharmacist should reach out to? Who should we engage with in between your patient visits to get them adherent to their medicine, to talk about lifestyle changes, and again, maybe engaging the nurses with that as well. So I guess those are some of the other things we've done. In the interest of time, I guess I'll stop and see if anybody has anything else to add, but those are some of the other things we've done.
Yeah, I would just add we work with renal failure patients. So again, the EMR can help us identify patients with reduced GFRs and then look to make sure their medications are being dosed properly and make sure they're on the right treatment regimen. That's an easy program to identify high-risk patients. I think we found like 50% of all the patients had renal insufficiency weren't even identified in their charts as having kidney problems.
Oh, wow. Yeah, that's great. That's a great response. And along those same lines, in thinking about all the different type of patients that you're caring for, what's the typical panel of patients that you might be managing at any given time? That question being for Stu and Kristen.
I guess I can go ahead and talk first. Again, I think it really depends on what that initiative is. So some of these things are very longitudinal, or they're chronic in nature. So I kind of talked about those diabetes patients. We may have our pharmacists helping to manage, 30 to 40 co-managing patients with diabetes at the same time. We kind of have a workflow where we work around our transitions of care, and we typically assign that to our pharmacist one day a week. So when they're doing those transition calls, there may be anywhere from 10 to 15 of those per day that need to take place. Then we also may just do identified patients for a comprehensive medication review. So those are people that may be up to 20, 25 medications. We may spend an hour and a half with that patient, but then we may not actually see them again. So it is a little bit variable. I don't think we have a set panel size. We certainly don't talk about panel sizes the same way that our physicians or our providers do when it comes to how many patients our pharmacists are managing. But we do have some ways that we're at least tracking what's our involvement with various patients.
How about you, Kristen? Yeah.
Sure. Yeah. This is Kristen. I would agree that the panel size fluctuates depending on whichever project we're looking at. One thing that I have approached, especially in 2018, as we've had some new CPC measures come to the program, I've kind of taken ownership of those and hoping to explain the clinical background behind it, so that's kind of how I've chosen my pet projects, just because they're new measures and we can't assume that all of our staff understands why it's important for a diabetic patient to be on a statin, or why it's important for someone to be on aspirin therapy, things like that. And so I've actually kind of focused on some of the new measures, and by carrying the torch of explaining that, educating that, then of course focusing on those patients that will benefit following some of those new CPC measures.
Great. Thanks, Kristen. I appreciate that. And I know there's been a lot of other questions coming in, and we will develop an FAQ to help answer those. But Amy, for the sake of time, I'm going to hand it back to you.
Oh, thank you so much, Jennifer, and thanks to all of our practices and speakers today. There's just a lot of information, and really we're just scratching the surface on this today. We're going to be delivering a lot more information to you throughout the year, and certainly over CPC Plus. But this is really just a way to get you guys started and help define this for you and thinking about it. So we hope you all go back to your staff and the rest of the members of your team. Really think about all those questions and considerations that we already discussed as you start to do this work in your practice. And so we'll be offering more information about medication management on various types of learning events, both at the national level and at the regional level. So certainly watch your newsletter for all these upcoming events in the CPC Plus Connect calendar. In addition, we have other resources that are available, of course, information in your implementation guide. And again, if you have information and resources that you're currently utilizing to help with CMM services in your practice, please do share those on Connect and ask your other practices that are part of CPC Plus for their recommendations and advice. We get some of the best information between the practices that are sharing, and that's why we always invite them to these events. And certainly everything that our practice partners here today shared has, I'm sure, been very helpful. But again, we're just getting started on this, so lots more information to come. Of course, we want to make sure for those of you who are looking for maintenance of certification, you have that information and you're able to access that. If you have any questions about how to do that and how to get credit, whether CEUs or MLC, we'll provide more information on Connect about the CEUs that are available for this particular event up on Connect as well. But again, we hope we do hear from you on Connect. We also really do appreciate all the input that you provide us on these events. So we're going to launch a survey, and it'll only take you about a minute, and we really, again, look forward to hearing all of your recommendations and advice so we can continue to make all of our learning events as valuable as possible to you. We're always looking at that information that you provide us, so please do take a few minutes to fill out that survey. We'd really appreciate it. And with that, we're at the top of the hour. I want to thank again all of our speakers from CMS, but especially from our practices, for all the time that you've taken today to share your successful strategies. We're really excited about continuing to work with you as we all get down this path and this journey of integrating comprehensive medication management services to our patients. Thanks again, everybody, and have a great day.
Thank you again to our participants for joining us today. We hope you found this webcast presentation informative. This does conclude our webcast. You may now disconnect.